Hi friends, good evening. I'm Dr. Ashutosh Gupta, and today we are going to talk about binder phenotype, right? Binder phenotype primarily has got four pathognomic features in the fetus. So what happens is this कि anterior ने जो nasal spine होती है वो थोड़ी hypoplastic हो जाती है, और जो मिड फेस हाइपोप्लेजिया है वो भी थोड़ा सा हाइपोप्लास्टिक हो जाता है। और यूजुअली व्हाट वी सी कि जो मिड फेस है हमारा वो कॉन्वेक्स होता है, इस केस में थोड़ा कॉनकेव हो जाता है। सो देयर इज अ मिड फेस hypoplasia and concave midface sort of a depression, and जो columella होती है वो भी hypoplastic हो जाती है। तो ये सब मिला के उसको binder phenotype बोलते हैं, right? And what we've identified is this कि binder phenotype, it is not that uncommon. So every now and then we do get a case of an binder phenotype. So what why we are doing this thing is this, that let us first see that how does it looks like on an 4D ultrasound and a 2D ultrasound. So how do we make a diagnosis? And second is the most important part is this, that probably in this binder phenotype, what now we are doing is we are going from a genotype to phenotype, right? So what we've identified is this that we can have a lot of chromosomal and syndromic etiology in the binder phenotype, and therefore doing a comprehensive genetic analysis to the baby makes more sense, right? Because on an ultrasound you really cannot pinpoint any particular sort of an etiology, as a matter of fact. So we will discuss all these things. Let us first go through these slides. So this is what we are seeing is at 4D ultrasound, but this is at 20 weeks, right? So it doesn't look that bad, right? Okay, so we are trying to look around for the face in a 4D, right? So what we can see is the nasal bone. We are seeing the ear. So because chondrodysplasia का है, so cartilage को हम देखने की कोशिश कर रहे हैं. Now there comes this sort of an hypoplastic anterior nasal spine, and so this is the flat nose that I was talking about. So this is how does it looks like, right? So it is a midface hypoplasia, flat nasal bone, and sort of a binder phenotype. This sort of an appears to be a moderate variety of a binder phenotype, right? And that is how it is, right? And so depressed nasal bridge and hypoplastic columella. And this how does it looks like in a 2D, right? So there is an element of a midface hypoplasia. Nasal bone is visualized very well, so eventually we can see the eyes, we can see the lens, and we would be in a position to see even the eyelids also. And but then there is a nasal bone is being looked around, but what we are seeing is this key, there is an element of a midface hypoplasia is there, right? So this becomes a moderate variety of a binder phenotype, right? And so how does it looks like in a 2D, and therefore how does it looks like in a 4D? What we've identified is this, that this binder phenotype in the fetus is genetically very very heterogeneous. So meaning there were environmental influences, infection, autoimmune conditions, vitamin K deficiency, some this we have also even identified a familial clustering of this maxillo facial sort of in a families across, and therefore we have identified it to be an autosomal dominant types, right? So hyperemesis gravidarum, ज़्यादा vomiting होना, vitamin K deficiency, and it is more so within IVF pregnancies. The reason we really don't know. And then we can have a warfarin, we can have some infections, and we can have some sort of the people those who are taking anticoagulants, or could be an autoimmune like SLE and anti-SSA, SSB antibodies. And so in autoimmune conditions also we have identified it to be more common. And these are the environmental influences, but genetically this can be very very heterogeneous. So meaning thereby that this could be part of some skeletal dysplasias also. Exclusively could be part of the chondrodysplasia punctatus. For CDB, what we try to look around for an epiphyseal stippling to the hip bone and the major joints, that is the knee and the ankle and then the whole of the spine. But then that is really very very difficult to pick it up those epiphyseal stippling at 20 weeks, and to say that probably we are not. So CDB could be an X-linked, could be an autosomal recessive. We've even identified it to be a familial clustering. Therefore, we have identified it to be an sort of an autosomal dominant sort of an inheritance. And then we can have collagenopathies also. And in fact, we can have like Stickler syndrome, in which we do have the element of the midface hypoplasia. So meaning thereby that making this diagnosis of a binder phenotype and ultrasound makes more sense, and then doing that investigations and that comprehensive genetic analysis to the baby makes more sense, because then on an ultrasound you really cannot differentiate and you really cannot pinpoint on that particular point that we are dealing with the skeletal dysplasia or CDPs, or probably we are dealing with the cystic syndromes types. So doing the genetic testing to the baby makes more sense, because from a genotype to phenotype we really can go. So we can do invasive testing. We can do a comprehensive genetic analysis, and then we can identify the genotype of the baby, and then probably we'll try to sort of narrow down or pinpoint to the phenotype. And then we can really talk about in a greater detail how exactly it is going to behave, what would be the phenotype, what would be the postnatal outcome, and a lot of things across. Right? That is how it is. So this is why we are doing this thing is a binder phenotype. We are going from genotype to phenotype, right? We are not making a diagnosis, or then probably we are not going to reach to a sort of an or narrow down to one diagnosis only by the ultrasound findings or a phenotype. We are going from genotype. We're identifying the genes, positive genes, if they are there any to the fetus, and then we are reclassifying the phenotype, right? Thank you very much for your question.